Señoras y señores, bienvenido. Hablo un poquito español, preferisco el francés, inglés, italiano, ma todo in spagnolo. Allora, I switch alla lingua and start to present in English this symposium. And let me thank the organizer of the Panlar for inviting a Eular representative for such symposium. That I think is a tradition that is started recently for many other leagues also to have some little talk from the Eular members about activities or other issues. So let me thank also the president of the ACR for staying so close now to us, and I hope we'll continue the cooperation as in the past in the best manner. We have a session here with 3 topics, but the majority of the contents will be discussing with you how the Eular manage the concept of recommendation for the treatment, at least of rheumatoid arthritis. And this is myself a little introduction about the pathophysiological basis and clinical basis for the development of recommendations. Then Professor Hans Bijma from Utrecht, Netherlands, will present to you some aspect of the education as a Eular manage the problem of education in Europe and maybe also outside. And finally, Dr. Haleta, that is from Vienna, Austria, will give you some much more detailed, technical, clinical detail how to arrange the recommendation, how to improve the recommendations. So I think now we should start, and I introduce myself as a speaker. And the talk you will see from the first slide of my presentation, it's related to the basis, pathophysiological basis of recommendation. Let me move to the desk, sorry. I will use this screen on my right because it's easier. I think it's easier in this position. And I would like to start with just the cascade, what we know about the cascade of rheumatoid arthritis. It's quite complex, as you know, and a lot of risk factors, a lot of factors enhancing the activation immune response that involve all the actors. So that is an important point because the different actors and product of the actors are today targets for therapies. And this very complex cascade do not involve just the joints, as we know, but involves also many organs with a systemic involvement. And of course, we will have at the end, and we have at the end, a different typology of patients. And this is one of the reasons, even the success and the need to have different drugs to treat in different steps and different aspects of immune response the patients. What is important, of course, is to consider the symptoms, because the symptoms of rheumatoid arthritis are really important. And we know that either the symptoms related especially to the joint pain, but also to the function of the skeleton and so on, and even of internal organs, is characterized by this systemic involvement and by circadian rhythms. This is a really important point, and you will see during the development of this approach to the pathophysiology of the disease how important it is try to optimize all the drugs we have available. So, of course, in the joints, we have cells-producing potent mediators, cytokines and cytokines and cytokines, and even not just only cytokines, but growth factors responsible for the angiogenesis and all the factors related to the growth of the tissue, so the proliferation of the tissue, that is an important issue, as we know, even in some way making very common the pathway of chronic inflammation with the progression of cancer. In any case, angiogenesis and cell proliferation are 2 important targets and are also targeted in the future probably for approaches. What about history and evolution of rheumatoid arthritis treatments? Of course, we have a 2 big family now today. We recognize the synthetic DMARDs and the biological DMARDs. And the earlier steps was a little, I can say, not convinced treatment, just based on the results, using goals, for example, gall salts, and many others approach with antimalarials, and enter in the history, as discussed this morning, the glucocorticoids in the 50s. Then going and producing new approaches with sulfasalazine, dipenicillamine, azathioprine, and methotrexate, probably the first anti-proliferative drug that was introduced in the 80s for rheumatoid arthritis, and now still a very important first step in the treatment, as we will discuss. Then other approaches included the leflunomide and the cyclosporine, all involved in immunomodulation or anti-proliferation like leflunomide we will discuss, and start the real era of biological DMARDs and more recent small molecules as approach. And so the earliest cytokines target for the treatments have been the TNF-alpha with different approaches. Other cytokines, of course, were found important targets, but as well also the cells, so-called B lymphocyte, because their involvement in rheumatoid arthritis is much higher than expected. And so other signals, molecules that are signals for the cooperation between the cells, costimulatory molecules are targets, and cytokines like IL-1, IL-6, and IL-17 already will become, and many of them have been successful targets. But more recently, also the smaller molecule having as a target that the intracellular signaling are becoming of interest. And major targets are the kinases. We know that inside each cell there are at least 500 kinases that mediate the activation of FKB. And here you can see shortly the difference between the biologics and small molecules. And difference, of course, are evident, especially the way of administration, the metabolic pathway, the cost, and also important to consider the mechanism of actions, that it's for biologicals different targets for the, at present, small molecules intracellular signaling. And so it's important also to consider the half-life. This is a question, seems of safety, but it's not so true from the early studies. So we are increasing the family of drugs for the treatment. And it's increasing in the way that already the recommendation produced by Eular in 2010 in some way have been modified in some steps related to the continuous availability of new targets and new approaches and the experience. The observational studies tell us where and how to optimize what we have. You see here, step by step, the different phases produced in this paper for the approach. As you get the early symptom in the patient, the morning stiffness, you have the idea that this is an early patient with rheumatoid arthritis. The first approach suggested at that time, it's a combination, and we have also, of course, we will discuss the pathophysiological basis between anti-proliferative drugs like methotrexate or others anti-proliferative like leflunomide, or at that time still surviving the idea of intramuscular goals that we don't know still now how works. This is the first step. But combination, important, as you've seen this morning during the presentation, combination with glucocorticoids. And this is an important point that I will develop in the next slides. Potentially, when we have an immune inflammatory reaction, all the cells involved in the immune inflammatory response are activated, so are proliferating, are synthesizing proteins, mediators, enzymes, cytokines. And so all are target for the anti-proliferative approach that at the end, in this case, became a sort of immunosuppression or downregulation immune response. And this is really important because the synthetic DMARDs principally exert this hard work, silent work, is an antiproliferative, downregulating, cooling the growth of the cells at the immune inflammatory response. This is a very important point. We know very well how methotrexate is able to inhibit the synthesis of purines and so damage the proliferation of the cells, and is this basis, of course, of the well-known side effects at the level of the liver, for example, these anti-proliferative effects, but also pyrimidine or other important components in the synthesis of proteins are targeted with leflunomide by inhibiting the enzyme, the hydroxyhydrosylase, that is involved in the synthesis of pyrimidines. So here, again, you damage the final product, the protein, that may be protein on the wall of the cells, may be enzymes, may be mediators, cytokines, or other proteins involved in the process. So this important approach with disease-modifying, synthetic disease-modifying, based on the antiproliferative effects, is the reason for their early employment. But it's important, as I mentioned, to combine glucocorticoids. Here in the 2010 recommendation, two different approaches were suggested, high dosage and low dosage. But we know now much better, the low dosage probably is the best. Low dosage exerts genomic effects, enter in the metabolism of the cells, so downregulate the production of proteins, cytokines, COX-2, what you want, at the level of the gene. And this is a very important point. Eular produced a lot of publication trying to find the best dosage and how it's possible to take the maximum effects from the glucocorticoid low dosage usage. And this is a very important topic that merits interest, because we know now that inside the cells, in the DNA, there are between 4,000 and 5,000 genes. They are sensitive to the action of glucocorticoids. Genes involved in the metabolism, genes involved in the immune response, in many other activities. And not all the genes are activated during the 24 hours at the same time. And so it's important, the timing, because you risk to interact with genes, activate and block them, or enhance them also. And this is an important point, because it depends, it's very important from the dosage and the timing, how you can modify or interact with the genes, genomic action. High dosage exert non-genomic action, completely different. And this is the basis for the side effects of glucocorticoids, because if they enter in the wrong time and in high dosage, in the metabolism, and expect side effects. This is an important point, really important point, because our body produces every night around 3, 4 o'clock the maximum of its endogenous glucocorticoids. And here also, the immune response starts during the night. Every immune inflammatory reaction starts during the night. Think about the gout, the allergy, the reaction to infection, and rheumatoid arthritis. We produce rheumatoid factor immunocomplexes. The cytokines also are produced during the night. And in the morning, we get the clinical symptoms of this immunological hurricane during the night. So naturally, after the switch on that is induced by melatonin, prolactin of the immune response, the switch off is exerted by endogenous glucocorticoids. That is for each of us, even healthy individuals. And we activate also the immune surveillance, again, due to this continuous circadian switch on, switch off. And this is the time to try to do the replacement therapy with low dose just at the time of the endogenous production, in order to avoid any inhibition of damage of the HPA, the circadian control of the endogenous production. As close you are at the natural endogenous production, much less you get side effects, at least on glucocorticoids resistance, so-called. Resistant because you inhibit the endogenous production with a daily administration, disturbing the HPA function. So this is an important point we will discuss this afternoon, that you get the highest clinical symptoms in the morning, and so if you want to downregulate and optimize the dosage and the side effects and reduce the side effects, the availability should be during the night. This is an important point. You see here, for example, patients, genes of patients. This is a panel of genes involved in immune inflammatory reaction of 2 families treated without prednisone and prednisone, and especially in presence of leflunomide. You can see the downregulation, the green, of genes, very important for immune inflammatory response, like some receptor for cytokines or kinases or even costimulatory molecules like CD86. So there is a real genomic downregulation that you can obtain at the beginning, especially with combination of anti-proliferation and genomic downregulation, gene-activated immune inflammatory reaction, and optimizing intervention of glucocorticoids. Now, this is true, this first step intervention with the combination of low-dose glucocorticoids and disease-modifying synthetic. But if you don't get results, you must think something more. You must target something more specific, less generic. And so, you must think about the possibility to intervene about other targets, specific targets. And cytokines are the most globetrotter in our body that are responsible from the fever to the joint pain. And so our target, for sure our target, when you fail in the first stage in the treatment, because also they are messengers for systemic involvement and growth factor also. And so you have to think about, in this case, to the continuing the synthetic bar, but thinking about biological bar. This is modifying. And this, in 2010, the TNF-alpha was and is considered the most important early target. We'll see some evolution over the time. Of course, there are, in TNF-alpha, several possibilities to modulate and to intervene. But not all the patients are similar. This was one of the reasons for the failing in the treatment with even TNF-alpha approach. Because we have a 70% of patients with strong activation of phagocytic cells, T lymphocyte, production of cytokines, inflammatory cytokines like TNF-alpha, L6, L1, and so we have the target circulating. And these are usually patients with no high level of rheumatoid factor, maybe seronegative, CPR not so evident, the anti-CCP not so evident, but a strongly inflammatory patient with joint involvement. But on the other side, maybe patient in transition or patient at the beginning, there are patients with overactivation of B cells. They produce antibodies, rheumatoid factor, anti-CCP. The classical patient that get easily Hashimoto, Sjogren, all the manifestation outside the joint. And here, the B cells are activated. And here, the best intervention, the early intervention, should be trying to block in the B cells, other than cytokines like TNF-alpha. So this is one of the reasons also for the resistance, so-called resistance to anti-cytokines in some patients, one of the reasons. And so, now the target for therapies are enormous, as you can see. Costimulatory molecules, new cytokines, and this is the reason why you have also kinases and searching for different approaches, working intracellularly, and non-using a non-targeting product, soluble product, but blocking inside the cells, the activation, with side effects that should be expected, of course. The drugs so available are blockers for costimulatory molecules, at the present especially blocking CD80s, 8086, blocking the CD20 positive B cells, but we have also approaches, especially in SLA, anti-BLyS, or activators, growth factors for B cells, and of course the cytokines, especially TNF-alpha with different approach, IL-6, and less in rheumatoid arthritis, IL-1. So the possibility to block at different levels, blocking the producer, the cells inside, blocking the producer, the cell outside, costimulatory molecule, blocking the product of the activated immune inflammatory cells, for example, the cytokines. There are different levels of intervention. And here become important to learn how to best use the drug. And this is a continuous evolution based on the results of the trials, on the observational studies, and the practice. So at this point, what happened? That you can use in phase 2 the TNF blockers, but also the costimulatory molecule blockers here, or the blockers for other cytokines, depends. You have several possibilities, but always based, if possible, on the analysis of the condition of the patient and the typology of the patient in order to obtain the best result. For example, if we consider the 3 different approaches I mentioned, the cytokines, the costimulatory molecules, and the B cells, you have different products, of course, and you have the possibility to modulate even cells that apparently are not directly involved. For example, endothelial cells. Now we know that endothelial cells express a lot of molecules involved in inflammation, and angiogenesis is very intensive in synovial tissues, as well as in the tissues on organs with inflammation. And here, endothelial cells talk with the cells passing in the blood. And here, for example, costimulatory molecules are evident also in endothelial cells. This is a very important point. Very, very close to what happened in cancer. Even in cancer cells, even in the development of this terrific condition, many of the passages I just mentioned to you are similar. And think about the approach we have with anti-proliferative. The same approach in cancer. Try to downregulate the cell proliferating, trying to block the growth, the angiogenesis, and low dosage of prednisone also, and so on, so on. For example, in this case, using a blocker, a natural blocker, CTLA4, blocker of these costimulatory molecules, it's possible with one molecule try to block all the cells that are expressing on the surface this important signal. This is the case, for example, to block the diffusion, the clonization of the process to cells completely different from the original T lymphocyte or dendritic cells, but also involving, for example, chondrocyte or osteoclast. Osteoclasts are expressing, again, a lot of molecules from TNF family to directly costimulatory molecules. And so osteoclasts, when we approach the treatment, immune inflammatory response become at the same time target. And you can explain also the success of this approach in the erosion progression, because we block indirectly, reducing the inflammation near the bone, the cartilage, but also we interfere with osteoclast overactivity. And the combination of 2 blocks tell us why we can really reduce the progression of the erosion. That means the destruction of the joint. But sometimes, as we mentioned, related to the typology of the patient, related to the step of the disease, is not always possible, even with this approach, to obtain the best results, using a combination of drugs. In the most recent recommendation published in 2013, as I mentioned, it's suggested the use of glucocorticoids low dosage, not anymore high dosage, because in high dosage, you risk much more to elicitate side effects, of course, and you get much easier side effects. Today, Hans Bijma presented to us the result of 2 important studies showing that the side effects are dose-related, for sure, and cumulatives. And less is the dosage, less you get side effects, even against placebo, as shown in a recent paper will be published in Annals Rheumatic Diseases. So this is an important point. And we must think about, sometimes if to continue the early approach with low-dose glucocorticoids, for sure we continue methotrexate or leflunomide, but we have also to think about how to manage when we fail also with this complex approach. And here there is, in the new 2013 recommendation, again, a sort of suggestion for the intervention based on the different typology of the inflammatory condition. That is based on biomarkers, on the clinical condition, on imaging. You can get an idea today of the severity of the joint involvement with the sonography you can have. And by biomarkers, the extension of B cells intervention, looking at the levels, at the concentration of rheumatoid factors, of anti-citrullinated peptides, you understand that B cells are overactivated. And B cells do not produce cytokines like TNF-alpha L6, so much like phagocytes or other phagocytical osteoclasts. And so it's important to think about how optimize the approach. And what I mentioned at the beginning, the concept of small molecules. Because inside each cell, there are mediators. In other words, when every biological or anti-proliferative drug or steroids interacts with receptors, and they move inside the cells to send the message to the DNA, to the nuclei, to downregulate the cells or switch the cells to other activity, they need intracellular signaling. And usually, the most important final target of intracellular signaling is the NFKA, nucleofactor kinase, nucleofactors kinase. That is the molecule that switch on, switch off. But inside the cells, as I mentioned it, there are almost 500 kinases. 500 kinases. In the last 7 years, have been tested with blockers, 400, 450 of them. Very few have been then tested in clinical condition, because when you touch the intracellular signaling, you touch any message to the nuclei, is not selected. And so you risk really to get side effects, much higher than when you use targets, clear targets. But in any case, this approach has been directed to 4 important cascades that, as you can see at the end, interact with the DNA. And one of the most successful cascade was considered the STAT-JAK cascade. Of course, even the different regulators of the NFKB activation that include a dimeric protein inhibitor of the activation have been considered target, but not easy to transfer in the clinical issues, this approach. What is important, as you know, that all the kinases, so intracellular signaling, small molecules, exert this important downregulation of the signal. And so if we consider at this point that all the cells use the kinases, all the cells, it's clear also that we have a multi-target cells, even maybe cells that do not work with high activity in our inflammatory process. So this is one of the reasons that is growing the interest, is the market, the possibility to downregulate the cells with intracellular signaling blockers, but still matter of careful analysis, the possibility to induce side effects. But you can imagine now we are very close to the control of the brain of the cell, intracellularly, in the machinery that activate the DNA. So we are really at one of the highest steps you can have. And so should be considered, not available in Europe, the possibility to block the signaling inside the cells. But there are some news related to the availability of the biological drugs. Because you know there are countries much more rich, I speak about Europe, and countries less rich. And so the use of biologicals is limited by the costs. And also, the biologicals, like us, have not a life without any end. The patents finish, and so need to replace them. But many biologicals are very efficient. And so it's pity to lose Leonardo da Vinci, Newton, and so on. And the treatment is to try to produce biosimilars, to clone them in some way. It's not correct, but to produce biosimilars. And what is interesting that biosimilar must be similar to compared to the originator. They should have the same qualities, efficacy, safety. They should not less efficient, but also not more efficient. This is the limit. Not more, not less. And so here you see the analysis of sugar content. We'd compare the first, the anti-TNF-alpha. The structures must be very close, even if it's clear that some sugar induced much easier neutralizing antibody, for example, cannot be improved at biosimilar from this point of view. And so here you see the first biosimilar was available, going back to the concept to block the cytokines, especially TNF-alpha. So we don't want to lose this important target in the cascade of inflammatory reaction. Of course, also many other diseases like spondyloarthritis and so on. And so now has been suggested to change a little the terminology of the drugs, disease-modified drugs we have. At least considering the possibility to have the so-called original biological DMARD and biosimilar biological DMARD that for sure will increase their presence in the world. Slowly, but at least in countries where it's not possible to treat a large number of patients because of the cost, probably will be a solution to give to everyone a high level of treatment. And so, in conclusion, I will finish earlier, this is the cascade. Of course, biosimilars going back to the past are the future. That's testified that several steps in the evolution of rheumatoid arthritis treatment is still very important. Some of the targets still very important, and we go back to try to even increase the market for such kind of approach. But of course, on the other side, offering always new possibility to optimize the treatment. And so I think that this is the most important conclusion I can give at the end of this talk, that generally we have to see at the future, but also we have to see back for the good things we have produced in the past, like glucocorticoids or TNF-alpha, because as the science progress, we can also approach all the drugs. Imagine methotrexate was synthesized in 1940 for the treatment of cancer, and then mutated in 1980 for rheumatoid arthritis. So we can even improve all the drugs and combine, because the combination treatment perhaps is the best approach now that we know where are the targets. And so we can look at the future in a very, very nice, very happy and very relaxed. Because I think we already have an armamentarium that may be optimized and implemented with new discoveries. Thank you very much. So I would like to invite someone who has questions to make questions. If not, the lesson, or I said too much. Okay. Oh, one question. You have a question? Yes.
Respecto a los glucocorticoides, que uno durante años se lo daba según el ciclo circadiano.
Sorry.
¿Sí? ¿Ahora? Sí, disculpe. Respecto a los glucocorticoides, que siempre damos según el ciclo circadiano. Cuando nosotros cambiamos acá para frenar las citoquinas proinflamatorias, vamos a tener mejor respuesta. Pero con el tiempo, ¿qué pasa respecto a estos dos ciclos? Uno respecto a la citoquina y otro circadiano.
You want to know when we use glucocorticoids. It's translating. You want to say that when we use the glucocorticoids, we interfere with endogenous circadian rhythm. When we use, generally.
Sí, exactly.
Yes, I understood your question. Yes, of course. If we administer even an injection in the joint, glucocorticoids, during the day, you know that there is a rise at 3, 4, 5 o'clock in the night, and then slowly during the day it's let down. What happened this time? In the brain and the hypothalamus, there are sort of sensors that recognize the decline of the glucocorticoids and start again the input during the night to produce again. This is a regular rhythm. Mm-hmm. When for even your style of life, you are a shift worker, you alterate this darkness-light rhythm, what happened? Your brain, under the action of the light during the night, continues to produce glucocorticoids, and you get a lot of side effects related to this quite physiological condition. Metabolic syndrome, hypertension, so the quality of life, the metabolic quality of life is a disaster. Shift worker, for example. When you administer glucocorticoids during the day, especially in the middle of the day, of course, as I mentioned it, in the low dose, of course, not high dose, low dose, you interact with genes involved in several actions, neoglucogenesis, for example, and it's easier to get hypoglycemia. But also, you give a signal to the brain that there is enough glucocorticoids in the blood. And over the time, the HPA, the brain, becomes lazy, do not produce anymore its endogenous. So what happened? That the patient gets the side effects, and they need more and more glucocorticoids because they lose the endogenous contribution. And so this is when you say, the glucocorticoids, doctor, I need more, because you have inhibit this circadian. When you try to, optimize and give at the same time of the night production, and remember that in chronic diseases or in stressful condition, your endogenous production is lower than you need. You ask continuously for the stress response system to your adrenal gland to produce, and then there is a sort of hypoadrenalism. When you give during the night, the brain do what he has to do. He starts to produce. What is important is to bypass the action of melatonin. Because if you give earlier than darkness and melatonin, you may induce some changes in other circadian rhythm, like sleeping. You make insomnia. So you have to let the spike of melatonin, and then at 2, 3 o'clock, melatonin is decreasing, and you can administer. So you reduce the classical side effects. One of the classical is insomnia or nervous people when you give earlier in the evening. It's okay?
Yes, okay.
Thank you.
¿Se escucha? Sí. Muchas gracias por su conferencia. Así como usamos la combinación de DMARDs sintéticos con biológicos, ¿existe alguna experiencia o la idea de hacer estudios entre DMARDs biológicos, combinación de biológicos para el tratamiento de artritis reumatoide?
The MARDs, synthetic like methotrexate, and biological like anti-TNF-alpha?
No. Combinar biológicos.
Sí. Two biologicals.
Yeah.
I think that it's better. Probably you can put the question to Dr. Haleta, that he knows. I was thinking too.
There have been some studies combining biologics, and what they found in general was that there was no increased efficacy, but increased toxicity. And actually, that is somehow, I must say, interesting, because by the increased toxicity, that means that there is some synergistic effect, obviously, some pharmacodynamic interaction. But by the lack of efficacy, it means we're not able to recruit more responders if you add another biologic to someone who's failing one biologic. And that's something that we need to think about in the future. But there's 3 or 4 studies in the past, and we've actually published a viewpoint last year in the annals where we're discussing these issues, and we have a summary of these studies.
Regarding the synthetic MAR, for example, to combine, this was also your question, leflunomide and methotrexate, for example, because we're very obvious to block purine and pyrimidine. There are in vitro studies showing that the results in cultural cells are fantastic, but again, you risk to get the side effects of too strong intervention. So you can try, we do in some patients, to reduce the dosage of both and combine them, but not full dosage. Because full dosage, it's easier that induce side effects, especially at the level of the liver.
Disculpen, pero uniendo las tres, ¿qué pasa cuando utilizamos 2 biológicos, que yo no lo haría?
Sorry, one moment.
Bueno, 2 biológicos, pero respecto a la osteoporosis, el denosumab, con otro biológico. En un momento se encuentran cuando afectan la parte osteoclástica, la señalización osteoclástica. O sea, un paciente con osteoporosis más una enfermedad del colágeno, altas dosis de corticoide, etc. ¿Se podría dar denosumab con un biológico, con otro biológico, anti-TNF o cualquier otra cadena?
In order to improve, to reduce or to improve the progression of the bone damage, you mean? But here again, the expert on biologicals combination, you are now, you are promoted. Do you have any data regarding the bone health, combining 2 biologicals?
Porque estaría en el hueso. 2 biológicos, denosumab con cualquier otro.
The studies that used the traditional, so to say, the traditional biologics, that was rituximab, that was, I'm not aware that there is any data or, in these publications on bone loss and bone markers. But there's denosumab, which is specifically going for the osteoclasts, and I think that the question is still out there whether the combination of denosumab with another biologic is useful. I'm not sure if there's any study that used the combination. I don't think so. But if people know, then okay. There are many experts in the room, I'm sure.
Thank you.
It's coming. Behind you.
Just an observation. In Brazil, we use denosumab, Prolia, in a lot of patients with rheumatoid arthritis, but not in combination with other biologic effects.
Denosumab might be, sorry, but denosumab might be different in that regard. It's not a typical inhibitor of the pro-inflammatory cytokines, but if you use a combination of these classical biologics, then you get problems in terms of safety. But denosumab might be different because it's relatively acting as somewhere else.
So, if no further question, it's the time to introduce the next speaker. It's my pleasure to introduce Professor Hans Bijma from Utrecht, Netherlands. He will present to you some issues about the educational activities inside the Eular. Thank you very much.